Our next guest is a peacekeeper. Dr. Barry Perrou is a retired 33-year member of the Los Angeles County Sheriff's Department. His last assignment was as commander of the hostage negotiations team, which he oversaw for 13 years. Barry holds a doctorate degree in clinical psychology and, as part of his educational requirements, completed a 2-year internship at the LA County system, providing intake and treatment for both male and female forensic inmate patients. Doctor?
Thank you very much for inviting me and for putting this on. It's amazing. And you have such excellent staff. Chris is amazing, and all your other folks are just great. It's very nerve-wracking for me to be here. I'd rather be in a shootout in South Central. Or eating donuts off the hood of a radio car. I've got to make a first apology. When I got dressed this morning, I put on a very light green suit that I thought was brown. My wife came to me and said, you know, when you speak before a crowd, you shouldn't wear green. It's really kind of against the protocol for speaking in public. And I said, oh, I thought it was brown. Does it go well with the tie? And she says, well, why are you wearing a brown or a blue tie? I said, I thought it was red. So let me just say to you now, if I've ever given you a ticket for running a stop sign or a red light, let me apologize now and get it out of the way. So forgive me. I think Ellen's topic is really good. It says criminalization of mental illness, not necessarily the person, but mental illness. And I've tried to put together some statistics for you, which I will show you. But first, let me share something with you. Do you know how hard it is to get a specific number of inmates in our jail system? I made 7 phone calls, and I'm within the system of mental health as a mental health commissioner for LA County. And I used to be in the system of the Sheriff's Department, and it took me 7 phone calls to get the numbers. And here they are in case you're interested, if you want to write them down, because it seems like we've had some differences. And I didn't have anybody out there counting noses, but I was able to get it off of a control board. In the jail system, as of 4/8/13, there were 18,642 people in the jail system, 16,160 males, 2,428 females. Of that population, 1,720 males were in the forensic outpatient unit. That's 1,720 males in the forensic outpatient unit, 25 males in the forensic inpatient unit, 286 females in the forensic outpatient unit, and 10 females in the forensic inpatient unit. The rest of the population, there are 1,000 other individuals in the general population who are taking psychotropic medications. So does that make us bigger than Rikers Island? I don't know, but it sure is kind of a sad statement about affairs for dealing with mental illness and what we do and what we can do. Points I want to make today are, if you don't want them there, the point of contact, point of entry. We've been talking about what do we do when we have that person in custody? How do we divert them from the criminal justice system? We have jail diversion programs, which are outstanding. We have drug courts, which are outstanding. We have mental health courts, which are outstanding. We do a lot of things post-arrest. And I think we need to look closely at why do we arrest? So the subtitle to my presentation is, and I can't see what you're seeing, is, if you don't want them there, don't put them there. And it comes down to why are we doing that and who controls that? Law enforcement is the social gatekeeper for our criminal justice system. And you noticed I have the word keeper, K-E-Y-P-E-R instead of K-E-E-P-E-R. And let me share with you, and this is a little bit of a show and tell that I'm going to be doing. The key to keeping them in is this. This is a Folger-Adam jail key. Sound familiar to anybody? Don't raise your hand, please. Don't raise your hand. These are jail keys. This is what keeps people in our jail system. This is what supposedly makes our streets safer, by keeping bad guys in our jail system. These are called Folger-Adam keys. The key to putting people in jail is this. Handcuffs. This is the key to overcrowding our jail system. We arrest many times, as Andy was saying, where maybe we should be using other options. Anybody recognize these? Don't raise your hand. Anybody have a pair of these at home? Don't raise your hand. Those are called peerless handcuffs. Don't play with them because I don't have a key. Lieutenant Paul Gagey from LAPD did a study a number of years ago about the number of mental health, or MI, mental illness calls, as he calls it, in 2003 across the nation. And I'm just going to kind of go over this with you. Rather than using a pointer, I'm going to go across the top. It's region, and down the left side is the region's population calls for service, says calls, MI, mental illness calls, number of calls per day, per hour, and minutes between. And in LA City, has a population of 3.8 million people, calls for service 850,000 calls annually, mental illness calls annually 68,000, which breaks down to 186 calls per day for mental illness issues in LA City, 8 per hour, and 1 call every 8 minutes. Do you think we have a lot of contact with how we can divert people from the system pre-arrest? Absolutely. LA County, 9.8 million people, most populated county in the United States, 2.2 million calls for service, 175,000 mental illness calls, 480 per day, 20 calls per hour every 3 minutes. Now, when we talk about LA County, we're talking about Sheriff's Department, we're talking about other police agencies, such as the municipal police agencies, private cities, CHP, first responders, such as Park Patrol, Park Police, Code Enforcement, and so forth, everybody else. Then you come down the bottom and you have the United States, 288 million people. This is, again, this goes back to 2003. Calls for service, 64.4 million calls for service in the United States, 5.15 million calls regarding mental illness, 14,000 calls per day, 588 per hour, 6 seconds between every call for service regarding mental illness. And we have options, which is really what I want to emphasize here, is because we do have a lot of police power and we have discretionary power, as I mentioned before. Option number 1, hospitalization. When a police officer comes in contact with somebody who could be arrested in the field, we have options. And many times the option is to hospitalize, but then you have to look at the consequences when you make that choice. Typical mental health call for law enforcement. I'm talking about the uniformed cop on the street. Now, I noticed yesterday nobody else used the term cop. They called them police officers, law enforcement officers. I was one, so I can use the term cop. I can get away with it, it's okay, and it's not really offensive, so if you want to use it behind my back, it's all right. Minimum time to handle a mental health call in LA County is at least 4 hours, between 1097 and 1098, and that's copobabble. Have you ever heard the term psychobabble? This is copobabble. 4 hours minimum without complications. Law enforcement does not have the ability to hospitalize to private hospitals. We can't do that. We don't manage insurance third-party payer systems. We do not have access to the Department of Mental Health Information System, their IS system, which used to be called the MIS. So we have no availability to their information. Now let me explain something. There's something to me that says, where's the lack of common sense here? We have a system of care over here called the Department of Mental Health, which in LA County, I think under Dr. Southern does an outstanding job given what he's up against, the number of consumers and patients that we have in the system, and the minimal budget that he works with. Even though it's a very large number, it's not enough, certainly, to take care of the people in our system. And we have Dr. Stephen Mayberg, who did an outstanding job running the state system of care, which was just amazing. But again, as he said yesterday, underfunded, and the cops got all the money. And he was right. We did. We have discretionary power to take the person from the point of arrest, which is the point of contact, and take them away from the point of entry by putting them into a system of care. However, we do not have that information into the information system within Department of Mental Health. Now, why is that so? Because there is an old belief, and probably based on truth, is that we in law enforcement are going to go into that system and then go seek out people with mental illness and harass them. People with mental illness, such as patients in our communities, are problematic for us. The reality is we prefer not to have contact with them. We should be the last person called to take care of that individual, but we're not. If you ever read 5150 of the Welfare and Institution Code, and it isn't something I would read before you go to bed, the number one agency in that section reads that law enforcement is noted first as being first responders. Then comes the mental health system further down the road. Why do you think Bruce Bronson saw that coming in under 5150 and put in 5150.1 and the other subsections of the Welfare and Institution Code? Because I think there was some belief back in 1969 when Governor Reagan signed the LPS Reform Act that we were going to be inundated when they put patients out of the hospital system back onto the streets. And it panned out. Many years later, it panned out. For that police officer who decides they're going to take the patient to a hospital that will accept where we can commit the patient, we many times have to take them over to be medically cleared first. Common sense. Why is this a police issue? And it comes down to, and it says further below, who's handling the crime in progress in your community? If we have, and this just adds on the time, if we have a situation where force is necessary, such as putting on handcuffs, and we have to use a level of force, it has to be thoroughly investigated, it has to be photographed, it has to be interviewed by a supervisor. 4 hours just become 8 hours, and we're about ready to move into overtime, which then starts to play with budgets. Then we also need to, if there's injury, to look at the treatment for the patient and the deputy if injury occurs. Field supervisor has to be substance, and coordination many times becomes a problem between getting the patient medically cleared and getting him into a facility that will take the patient. The two doctors bump heads, and now you have the clash of the titans, and we get nowhere with it. We become basically an ambulance service for a consumer, for a patient. And we have been pushing for the last 14 years, something that we started a long time ago, to get patients transported in ambulances. Gee, common sense, what a novel idea. Why were we ever doing it in the backseat of a police car in the first place? It's cruel, it's inhumane, it's uncomfortable, it's panic-provoking. Everything, it's disparaging to the family. We take a patient from a community setting, from somebody's home, and according to LAPD, about 88% of the calls for service regarding mental illness comes from a loved one or a family member. This is not the person standing in the middle of the park baying at the moon with aluminum foil on their ears. Let's get real about this. And I'm basically talking to you in some ways as if I were teaching a class at the academy or trying to train police officers. Let's get over that. What we are doing is being a part of the system of care. The family calls. We take the patient. We shouldn't be putting them into a cage. That's what we refer to as in law enforcement. The term is not incorrect, but when you think about putting a psychiatric patient in full-blown acute panic into the backseat of a police car, it's very contraindicated to the well-being of that person. Why is it if I break my leg, I'm going to get an ambulance? Why is it if I have a psychiatric injury, I'm going to get a police car? I did 8 hours in the backseat of a police car on Wednesday, riding along with the mental evaluation team. It was so small, I had trouble getting in and out of the back seat. The psychiatric patient that we detained had trouble turning around, to get the handcuffs on because he was flailing. He needed to be handcuffed, and get him in and out of the car. We should be using ambulance systems. Nobody wants to deal with it. Again, I go back to the fact this has been a 14-year uphill battle. 14 years. You imagine the number of people, looking at the calls that I had up there before, that have been put into the system. Now, this is a blending of systems of mental health and law enforcement. The other thing that we have to consider is that we spend a lot of time in law enforcement dealing with calls about mental illness. It really becomes an unfunded mandate when you look at the services that other agencies should be providing, such as Department of Mental Health, their Psychiatric Emergency Response Team, which is Psychiatric Medical or Mental Health Response, PMRT, Mental Health Response Team. Some of our money should go to their pot. Now, we take 4 hours and add time to it on the option 1. Option 2, arrest process. It takes approximately 2 hours. I can usually get Andy in and out of a system of law enforcement, jail, and out of my car, and I can be back on the street as a cop within about 2 hours. Life for Andy after that is not my problem. Not that I don't care, but I've got 2 calls down. I've still got 2 calls to handle, and I've got to handle them in the next 35 minutes before I get off duty. Otherwise, I'm going to have my supervisor on my back saying, "Why are you dragging your feet?" Part of the understanding has to be that we need to realize in law enforcement parlance is that when you handle a mental health call, it will take more time than handling the typical disturbance call. We need to give it the appropriate amount of time. We need to address these situations as different from any other call for service. And this comes down to training. By taking Andy and arresting, and I'm not going to use you anymore, and I'm not going to pick on you, but I'm going to give you my card. It says, "Get out of jail free." I can be done with Andy in 2 hours. But what happens to the system that we keep crying about in law enforcement? We have overcrowded jails. We have, and on the hospital side, we have overcrowded hospital systems. If I'm going to protect my job in protecting the community, the jail system, even though it's part of the sheriff's department, is going to get the patient, is going to get that arrestee. It's going to go through possibly that system, especially if they're demonstrating psychiatric behaviors. They're going to go through that system. The jail is another aspect of law enforcement that I, as a patrol person, am less concerned with. Then you have the hospital system that says, "We're running out of beds." And a very astute police officer once noted in an interview with the LA Times, after hearing about the person saying, "We're running out of beds," the police officer said, "We're running out of back seats." And we were, and we are still running out of back seats. The policies do not mesh, and it's interesting that in this book here, the American Bar Association, 1984, Criminal Justice Mental Health Standards, it says that the 2 agencies, law enforcement and mental health, will or should, this is a should book, not a will, must, shall, but should develop cooperative process and procedures to enter people into the mental health system and take care of them. And law enforcement should be just the conduit of moving them there. And we talk about behavior of law enforcement. We need to look at what I could have done in the situation of somebody who is under a psychiatric stress moment. What could I have done as a police officer in uniform to calm down that individual? Or just my appearance, just my presence is going to escalate the situation. I know that. So my job is going to be twice as hard. This goes back to training. I can aggravate almost anybody with my training. I can aggravate almost anybody to the point where I can arrest them. A good traffic police officer can take any car, brand new car, off the manufacturer line and find traffic violations in that car. So it's a matter of what are we looking for? Am I going to, excuse the expression, piss off Andy and be done with him in 2 hours? Or am I going to not escalate him, take care of Andy, get him into a system of care, but it's going to take me 6, 7, 8 hours. And then the backlog follows. The choice of options sometimes can be based on supply and demand and the system of care in place to provide services to the community. And I'm talking about health services, mental health services, public social services, law enforcement as your gatekeeper, which we are. Subsequently, this decision gets pushed back down to the police officer, that discretionary police officer ability to make an arrest or not. It gets pushed back down to the streets and the discretionary of the police officer, and it goes back to what the title of this presentation is, point of contact, point of entry. Recommendations to prevent patients from becoming inmates. First and foremost, law enforcement training. Currently in the state of California, we have 8 hours dedicated, and it's called Learning Domain 37. We have 8 hours dedicated to training police officers about illness, blindness, hearing impairment, developmental disabilities, autism, Alzheimer's disease, mental illness, report writing, and we're compressing that into 8 hours. By the time you take 1 hour of training and you give 10 minutes of break, and all of you have been to meetings before, 10 minutes turns into 20 minutes, the whole thing gets diminished down to far less than what it should be. And when you start mixing disabilities with disabilities, and they all require a special handling, we're not doing any of them any justice. So the training should be at least 20 hours, and I'm not talking about specialized crisis intervention CIT training. I'm not talking about specialized mental evaluation team training. I'm talking about every police officer to understand what the consumer is going through and how they should be a helping process as opposed to a rapid problem-solving process, which means that we're going to have to push back against the system up supervisorial ranks saying, I have a call regarding a mentally ill patient. I'm going to be more involved and more time involved in this situation. Number 2, develop multidisciplinary field response teams, which my support group is at the rear left of the department or of the room here today. This is our mental evaluation team. It's also folks from the Transit Services Bureau. These are the individuals, the folks, police officers and mental health professionals who ride the transit systems, the blue line, the red line, to deal with the mentally ill folks that are on our train systems. Can they have utilized police powers? Absolutely. Is it their first option? That's really not what their service or intent is. My partner who developed the mental evaluation team with me 20 plus years ago, Linda Boyd, is here. Raise your hand, Linda, so they can see. These are the folks that deal with, if you excuse the expression, the icky population. We're not afraid to deal with them. Police officers typically aren't afraid to deal with them either. But everybody says, not in my backyard. I don't want to see them. If I could see them from my porch, I'm not going to be happy. This is where the rubber meets the road. So we developed mental evaluation teams, met in SMART programs, HOPE programs out of the city of Pasadena. Other cities are now starting to put together teams, multidisciplinary teams of a mental health professional and a police officer working full-time as partners in the field responding to calls about 5150, possible mental illness on board, family disturbance in a family member. And this is another thing about law enforcement. We don't listen to anybody. I got the solution. Take him to the hospital or take him to jail. The family knows. Part of the training is talk to the family. The family knows everything. You don't know where to take them? Ask the family. Take them to where the family has had the patient released to them before. So we have multidisciplinary teams. On my ride along the other day, it was amazing to work with 2 of the Met officers and how their systems collaborated to the betterment and placement of a psychiatric patient in the middle of a park, and he was screaming and acting out and scaring the kids, and he was delusional, and we were able to get him into a hospital system, and he was transported by ambulance. Technology is something that we need to embrace. The local field patrol car deputies arrived on the scene because The Met team did not know who he was. He had no identification, and his name was Puddintain. What was your name, Puddintain? You've heard that. And he's going on about what his name was. So the local patrol car came over. They did a fingerprint, ran him through the jail system, and we came back with an exact hit of who he was and what his name was based on previous bookings into the LA County Jail. And from that identification in the field at the point of contact, we were able to run him through the IS system for Department of Mental Health, find out his history, and take him to a hospital or have him sent to a hospital by ambulance for treatment. Was he arrested out of the park? Absolutely not. This is where we need to blend the systems. Thank you. It was, I was jazzed. I mean, it made me want to sign up again. Too old. I know the truth. When you talk about Met and SMART programs and HOPE programs and all the other programs that are out there up and down the state of California, I'm down to it. She's got the hook. We talk about assisted outpatient treatment. Who's going to go out and deal with that patient who's not in compliance? It's never been in the legislation that I've seen that we're then going to pay for and fund whatever it is. And we need to have safety and security when we go out, when mental health people go out from their offices. Met and SMART teams are absolutely fantastic for that. Jail diversion, we have a very active jail diversion program, diverting thousands of people away from incarceration if they're compliant with their treatment. The first woman in law enforcement in the LA County Sheriff's Department back in 1919 who lost her life was in the process of returning from transporting a patient down to Metropolitan State Hospital. We've been involved in the system. I think we've lost some of our focus and we've lost our way. I think through meeting with executives of the Sheriff's Department, meeting with executives from LAPD, meeting with the big agencies, becoming a singular voice. When you think about the mental health system, you have DMH. Think about the health system of hospitals, you have DHS, with Department of Health Services. But we have 50 different police agencies in LA County and probably 45 different policies. What if we came together under solidarity and worked together as a single agency policy that worked with mental health services and the other public service agencies? The other thing, real quick, the Pavlovian principle. We in law enforcement are trained, you put handcuffs on somebody, you're helping clean up the streets. So you've got the task, click, click, the reward, the streets are safer. Click, 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 the patient, click, click, the patient, And we have to differentiate in our training, law enforcement training, is that we should not be doing click, click, the patient into the jail system. We need to recognize that there has to be option number 2, option number 1, which is taking the patient into the hospital system. There's another way to look at this too. Give Department of Mental Health their own police department, because that's what you need us for, is 5150, which is you cannot turn police officers away. With that, that's where we get prostituted. That's probably not the best word. But we get utilized because we have police powers, and under Welfare and Institution Code, we cannot be turned away. Can they turn Department of Mental Health away? Yeah. Can they turn you away as citizens? Yeah. Can they turn the cops away? No. Interesting stories behind it. So we get dragged along many times, kicking and screaming, because they need our signature on the 5150 application. And in training, there's issues specific. They're calling me, I'm sorry. Issue specific. In training, there's nice to know information, the culture of mental illness, other aspects, and then there's the need to know. And the most important thing that I emphasize in the training that I have done and that I've been able to design is that first 2 minutes of contact. Step back, clear a path, don't crowd, don't encroach, don't escalate, de-escalate, calm the patient down. calming the patient down. You're less likely going to be using force as a police officer. You're going to be more likely to gain the trust of the person, get them through those 2 minutes of panic and fear, and that is the nice to know information. When you're dealing with cops, you always have to talk about officer safety. Major buzzwords, officer safety. And if you can put it into terms that this is going to make you safer, officer, by giving them that space, and that officer is going to say, okay, I'm not going to get hurt. I'm not going to retire at the age of 28 with broken back that I can never walk again. I'm going to give them that space. And by doing so, we de-escalate the situation. We shift the management from panic and fear through the hallucination and delusion back over to the police officer who's really just on a fact-finding mission. Oh, I could go on and on, but I'm not going to do that to you. Pre-3 strikes. What if we had a system in LA County that anytime we have the possibility to arrest a consumer, a patient who has committed a minor crime, such as stealing a loaf of bread because he or she is hungry, can we arrest? Sure. Can we commit? Sure. Misdemeanor, discretionary police powers. What if we put them into a system, a central data bank of people who have committed a crime by name, and we don't prosecute, but we take them to the hospital? And after the third time, or on the third time, 1 and 2, this is pre-3 strikes. After the second time, the third time, obviously the system on the streets of mental health care, he's falling or she's falling through the cracks. Then maybe we need to arrest, put them into a system. It's not a pretty system, but they're obviously not being treated. We get them into a system in the jail system where they can be treated, hopefully treated. This would be something that we could do and has been talked about. It's a pre-3 strike system. The other thing that we developed years ago, and it just kind of petered out, and sometimes it's sad to be ahead of the curve on some of these ideas. It's the emergency services index, where we have a consumer like we had 3 days ago, a patient with no name or ID, but he's got specific tattoos. He's got a specific theme to his delusion, and we can, anytime law enforcement, and this has gone through county council and the legal system, that we encounter that individual, we can put him into a data bank. So when he shows up again and we don't know who he is, we can return him home. It also works with Alzheimer's patients. It works with other dementia disorders, people with thought process and memory problems. We can do this. It's not a problem. It's just going to take the cooperation of everybody to bring them together. So with that, Marie's giving me the real evil eye here. So let me take questions. Michael.
I wanted to give a shout out to my Long Beach police and our collaboration. We not only have those two levels you were describing, the cultural training and the combined team, we also have something called the Quality of Life team in the downtown area that works alongside us. They have hotel vouchers, and then they call us. They take people's Social Security appointments to be able to get the evaluation of Social Security, sober livings. They have a few hospital beds they can use. They keep track of people once a day, keep track. Our nurse practitioner goes out with them to assess people, not for hospitalization or jailing. To assess where they go, they'll bring them back and say, did you come back and see with us how they're going, and we'll try to discuss if they have longer stay or not stay. So there's actually a third level of actual community policing that we do together as a partnership. And I'd also like to add here, on your pre-3 strikes, you guys are permitted to do FSP referrals. If someone's bounced in and out of a hospital several times, that means the standard clinic isn't working. There are FSPs in every neighborhood. That person can refer to that for more intensive community treatment before you give up and do treatment in the jail.
Make sure we get Dr. Reagan's name on that list of committee members. Thank you for volunteering. I appreciate that. And your information. Thanks, Mike. I appreciate it. You know, one of the other things that we did it over La Casa with Dr. Regan is that we put police officers in the basic training for mental evaluation team training. We put them in 4-point restraints for 30 minutes. I did it. And it was amazing. It gives you a real clear insight to the loss of self, a loss of freedom. And they don't commit crimes or walk the streets anymore. Our officers are doing much better now. Yes.
actually have to take this minute to thank you. My son was taken in less than a year ago through the Met team. And I can't tell you how fabulous, and I probably know some of you back there, I can't remember all your names. But I want to tell you when the system really does work, and the other big component that made it work, and I was only lucky, because you can't take them somewhere if a hospital doesn't have a bed, right? And I was just fortunate that my husband's on the medical board at Kaiser, board of directors. So we live in Orange County, but my son was up here in LA, and he knows all the directors at all the hospitals. So my husband set it up, called Sunset Kaiser, said, I'm going to be trying to get my son in there, have a bed ready for him. Because I knew that if there's not a bed and my son is going to be resistant, that this could turn into a criminal situation, because he's going to resist. But if the Met team knows and they have a place to take him, and that's how it worked. It was classic. We set it up. They picked him up. They took him right to the hospital. He went right into the hospital and then stayed 11 days at Kaiser.
That's the way it's supposed
And
to
on
work.
medication. It works, and I never wrote my thank you letter, and I promise you guys I will. I still have all the names of the people that were on the team. There were nurses, psychologists. It worked perfectly, but it only worked because I knew people in the system. I'm on the Orange County Mental Health Board, so I knew the medical director in Orange County who got me in touch with the person I needed to get in touch with up at this system. And of course, then my husband, being a physician, was able to make it arranged. But when it works, if it works well.
Yes.
Now,
thank
what
you.
failed was I tried to use the system of not forcing him. I called the CAT team first up here, which, by the way, I sat on the phone for 45 minutes waiting for somebody to answer the phone. And when they finally did, they said it would be a few hours before they could send somebody out to go try to evaluate him. When they finally did, they got there, and my son would not give them the time of day. He said, go away. Unless you've got $750 a month to give me, I don't want to talk to you. And they left because there was nothing else they could do. So we could have even avoided the Met team if we had another mechanism of just being able to send somebody in that could maybe have a little bit more teeth to it to help talk to him. But anyway, we definitely need that collaboration, and I thank you so much again.
Thank you for your words. I think that's one of the reasons that the Met team was developed, and I've got to give a lot of credit to Linda Boyd, who with me for 2 weeks worked it, and it was just amazing what we were able to do. It was such a good, feel-good 2 weeks. Yes, ma'am.
Yeah, I had the pleasure of teaching CIT training during the Kelly Thomas incident in Orange County, and dealing with the officers during that incident. But if I could change anything, and I talked to our sheriff and everybody, there's no hand holding yet. But if I could change them from saying, our hands are tied. I said, if I hear that one more time, their hands are tied. Because nobody wants the liability or the responsibility of someone who won't go voluntary. And I appreciate your comment on FSPs, but they're voluntary programs. So there's absolutely nothing anybody can do when somebody doesn't voluntarily participate in a system. So then they are ending up in the criminal justice system, and there is no, as much as we love to think there's treatment, most do not receive any treatment in the criminal justice system. They receive criminal charges on top of their illness. So we actually work with families all day, throughout the day, call us because their sons and daughters are incarcerated and are horrified that now they've got a hugely compounded problem that they thought would be a solution, because now there is no solution even in the jail systems anymore. People don't want them, they don't feel it's a responsibility. People getting arrested for their hallucinations, making false police reports, you know, you name it, they're incarcerated. But I applaud you. We've tried, and if there was one suggestion you could give to bring it together, I don't know what.
Well, you know, I'm going to go without the mic. The sad part is that each county has its own fiefdom. So your county in Orange County has a different system of working together than they do in LA County.
Right.
And you have to conquer that. I used to work for your sheriff, Sandy Hutchins.
I love her.
She is, I do too. Everybody loved her. We were just brokenhearted when she left. but she is a godsend for Orange County and very open-minded. I mean, she knows about the Med program. She was my boss when I was working hostage negotiations, and she knows about it. And those things can be spent. You just have to find that sympathetic ear and the least amount of pounding on metal, which is the similarity is that you got to get past that barrier because people do listen. Once you put a humanized mental illness to law enforcement, you're going to make that penetration. You give a cop an opportunity to save a life or to help somebody, they're going to do it. But unfortunately, what we're seeing now, or what our police officers refer to, is Jack Nicholson sticking his face in the door saying, Johnny's back. And that's their perception. We need to change that. Take away the fact that yes, mentally ill people can be problematic as far as dealing with the system. But we are the gatekeeper. We also have 5150 powers that I, as a police officer, cannot be turned away at specific hospitals. So they can't say no.
But they are chastised for writing too many because there's no beds. So
Who chastises?
the behavioral health care department.
Isn't that unfortunate?
Yes,
I'm sorry.
they actually monitor the numbers and
Right.
it comes back through the law enforcement, they write too many.
We're videotaping.
Excuse me. Thanks, Chris.
Let's do one more
She
question.
was just saying how handsome I am. Jim.
Barry, years ago I remember having a conversation with a colleague of yours who had been a Met officer for a substantial amount of time and had gone back out into the community as a regular police officer. And his comments struck me as very, very interesting in light of the training and stuff that you're talking about, because he said that, although he did this amazing job as a Met officer working with people with mental disabilities, he felt he was no longer at the right level to be a good cop on the street. That somehow the training involved with the kind of de-escalation and work that you're talking about that you need to do as a Met officer interfered with the sort of way that he normally would have reacted in the street. Do you have thoughts on that in terms of curriculum?
It's called police paranoia. Basic level of survival is police paranoia. Don't trust anybody. Don't let anybody near your gun side. Those are the things that you don't necessarily do when you're dealing with a patient. You deal with them individually. You understand their behavior, and a police officer at some point has to figure out, is this person under the influence of meth, or is this person under the influence of a psychiatric disorder? And once they get comfortable, once we get past the danger, are you going to hurt me question in that police officer's mind, they're going to deal with the mental health issue. But I think in response to Jim, see if I can answer your question. Yeah, you start to see people in a more humanistic way, and you tend to put down the edge a little bit. But I'm going to take difference with what he had to say, or she had to say, is that I don't think it made him a worse or a less protected police officer. I just think maybe he opened up his heart. So I think that may have been a while ago. Today this officer would be prime, this deputy would be prime on our streets, role modeling for other police officers. We're seeing an evolution. It's a work in progress. I'm never going to see the end of it in my lifetime, and that's fine. But we've got the wheel rolling along. You have helped a lot in that, Jim, by getting that going and throwing your support. In fact, offering me up for this presentation. Thank you. I'll see you in the parking lot. I'll be more than happy I think it's time for me to get off. I'll be more than happy to meet with any of you in the back at break or whenever it's convenient. But thank you very much.